Bună seara! Mulțumim frumos că sunteți aici în număr atât de mare. Sesiunea următoare este introdusă de domnul dr. Constantinos Papazizis, specialist în cancer renal și cancer de sân în Grecia, care va discuta câteva aspecte privind secvența terapeutică în cancerul renal metastatic.
So we had a chest and abdominal pelvis CT scan which revealed the presence of a malignant mass in his left kidney and multiple bilateral lung and bone metastases. He had a lung biopsy that revealed the presence of metastatic renal cell carcinoma, and the question is, what is the next step in approaching and treating the patient? So this is the general scheme for the initial management of metastatic renal cell carcinoma. Initially, like most patients, our patient had a cytoreductive nephrectomy which showed a clear cell RCC. He then, like most patients, was found not to be eligible for either resection of metastases or high-dose IL-2, and eventually, like most patients, targeted therapy was his treatment of choice. And I will not review in details what you all well know, but in general, we have two groups of therapies for metastatic renal cell carcinoma. We have the inhibitor of the VEGF system, the TKIs, sunitinib, sorafenib, pazopanib, axitinib. We have an antibody, bevacizumab, and we have two inhibitors of the mTOR, everolimus and temsirolimus. Now, the choice of the first-line targeted therapy is based on a risk stratification nomogram. One might use either the hang nomogram, which I usually use in my practice, or the modified memorial. Both of them use 6 simple clinical risk factors, like the performance status, anemia, hypercalcemia, and then you count the number of risk factors. No risk factors, the patient is favorable, 1 to 2 intermediate risk, so most patients will fall into this category, 85%. About 15% of our patients will be poor risk with 3 to 6 risk factors. And our specific patient was intermediate risks per either nomogram. So these are the most recent ESMO 2012 guidelines for the therapy of metastatic renal cell carcinoma first line, and they are based on randomized clinical trials and the real-world data. I will start from the right side. 20% of our patients with non-clear cell histology, papillary, chromophobe, etc., we don't have real level 1 evidence. So if you can, you should put the patient on a clinical trial, and otherwise you might use either sunitinib, sorafenib, or Toricel. We have some data regarding these compounds based on subgroup analysis of the Toricel ARCC trial or expanded access program, small phase 2 and observational studies. And moving to the middle of the slide, about 10% of our patients, clear cell histology, poor risk. You might use either Toricel or Sutent as a reasonable alternative. But most of our patients will fall into this category, 70% of good intermediate risk, clear cell histology. And for this patient, we have most of the randomized clinical trial. The highest level of recommendation is for sunitinib, 1A level of recommendation. Other alternatives, the combination of bevacizumab interferon 2A, pazopanib 2A, and for selected patient, one might choose sorafenib or high-dose IL-2 as first-line therapy. So this is a list of the pivotal trial, which all of you well know, and I will just briefly review them. Sunitinib was compared to interferon, a pivotal trial published by Dr. Motzer in the New England Journal of Medicine in 2007, with a later update 2 years later in the JCO, compared to interferon, the historic standard, with a response rate of almost 50%, more than doubling time of the progression-free survival, 11 months versus 5 months, and an overall survival of more than 2 years versus less than 2 years. And among the different pivotal trials, this is the highest response rate and the only PFS, the only overall survival of more than 2 years achieved for any of the compounds. The combination of bevacizumab and interferon was compared to placebo with a response rate of about 30%, a PFS of about 10 months, and less than 2 years overall survival. I usually do not use this combination. It's IV, non-convenient, and there is the interferon-associated toxicity. pazopanib was compared to placebo with a response rate of about a third, 11 months of PFS, and less than 2 years overall survival. Sorafenib in the first line was compared to interferon with a pretty low response rate of less than 10% and a PFS of less than 6 months. So I usually do not use sorafenib in the first line setting for metastatic RCC. And Toricel in poor prognosis patient, the ARCC trial, compared to interferon or their combination with a response rate of about 10%, a PFS of almost half a year, and an overall survival of almost a year. So until recently, we had no direct comparison between the currently available compounds for metastatic RCC in the first-line setting. And recently, the COMPASS trial was published by Dr. Motzer. So this is an open-label study that randomized patients with clear cell histology, no prior therapy, first-line therapy, randomized them by 1:1 to either pazopanib, 800 milligram continuous dosing, or sunitinib, 50 milligrams, 4 weeks on, 2 weeks off, the usual schedule. The primary endpoint of the COMPASS trial was to evaluate to compare the PFS, the progression-free survival, between pazopanib and sunitinib. And pazopanib would be defined as to be non-inferior to sunitinib if the upper bound of the 95 confidence interval for the hazard ratio would be less than 1.25. So regarding the primary endpoint, the progression-free survival, pazopanib was shown to be non-inferior, not significantly worse than sunitinib, with a PFS of 8.4 months for pazopanib. Sunitinib 1.1 months longer, 9.5 months, but this difference wasn't found to be statistically significant. The response rate was higher for pazopanib, 31% versus 25% for sunitinib. Now this 25% for sunitinib is by far less than what was obtained in prior trials, what we see in the daily practice, and I will discuss this later. An interim analysis of the overall survival revealed that the two compounds are not significantly different, 1 month difference between pazopanib and sunitinib, 28-29 months. The quality of life was better with pazopanib, which has less off-target toxicity. And the quality of life benefit with pazopanib in the COMPASS trial is further supported by the PISCES trial that was presented by Dr. Escudier in the 2012 ASCO annual meeting. The PISCES trial was a randomized, double-blind, crossover study, so patient got 10 weeks of either pazopanib or sunitinib, and then crossed to the other medication. And after the second period of 10 weeks, they were asked what's their preference. Now, I must tell you that from a real-world perspective, the quality of life results of the COMPASS and the PISCES trial are not surprising for those of us that gave pazopanib and sunitinib to a large number of patients. I see that on a daily basis in my practice. Pazopanib is a bit easier on the patient than sunitinib, but one shouldn't mistake easy or quality of life with safety. It doesn't mean that pazopanib is safer with liver toxicity, diarrhea, etc. So how to select the treatment among the available options for a patient with clear cell low intermediate risk? I'm talking about the majority of patients. I'm not talking about the non-clear cell histology or the poor risk. So in my opinion, in my practice, if quality of life is my primary treatment goal, and this is in a minority of patients that doesn't care about the efficacy but the quality of life, then I think pazopanib is probably a better choice with less off-target toxicity. And remember, it doesn't mean that it's safer. It's just easier on the patient in terms of quality of life. And again, in a fragile patient, which I personally defined as a ECOG status of 2 or more, a low than normal ejection fraction, and significant cardiovascular toxicity. So again, in a minority of patients, about 20% of our patients will be fragile per these definitions. Then in a fragile patient, I might choose pazopanib rather than sunitinib. However, the majority of the patients that you see in the clinic are fit, have good performance status, and they are more interested usually on the long-term outcome than the quality of life. And for this patient, I personally choose sunitinib as my treatment of choice, again, with efficacy in my primary treatment goal, because I consider two major issues. First, the efficacy data in pivotal trials, and second, some open question that some of us has regarding potential biases in the COMPARS trial that I will discuss. So I will not repeat the efficacy data of the different trials, the highest response rate and overall survival of more than 2 years with sunitinib versus the other compounds. So what are the open question and potential biases that one may found in the COMPARS trial? So there are mainly 5 open questions that I will discuss. First, the schedule of sunitinib. So we know that in patients treated with sunitinib, the response rate, the PFS, and the overall survival, so the outcome, is related to the dose and the exposure. So you should make every effort to keep the patient on the 50 milligram dose in order to have the optimal outcome. We have clinical data to suggest that the VEGF receptor inhibition is 100% when you give the patient 50 milligram dose and decreasing to about 66% on the 37.5 milligram dose. We have also clinical data to suggest the association between the dose and the outcome. We have the Motzer meta-analysis from 2010. I show you here, we have an American, Israeli, international database, 400 patients treated with sunitinib. There's a significant difference in terms of PFS and overall survival between patients that were kept on the 50 milligram dose versus those that had a dose reduction to 37.5. Other groups showed similar results, like Dr. Schmidinger from Vienna. So every effort should be made to keep the patient in the 50 milligram dose. And today, after 6 years of experience with sunitinib, we know that in a patient with significant toxicity on the 4-2 regimen, a common practice is to use an alternative 2-1 schedule. So 2 weeks on treatment, 1 week off treatment, in order to keep the dose intensity while decreasing the adverse event and improving the quality of life of the patient. Now, I have to say that the 2-1 schedule is not registered, it's not FDA approved, but it's what many of us do in the clinical daily practice. Prospective trials of this alternative schedule are ongoing, like a Canadian trial, so we will have prospective results in a couple of years. But meanwhile, we have some interesting retrospective data I will show you. So from a real-life perspective, I can tell you that about 60% of my patients that I start on the 4-2 schedule will have significant toxicity on Sutent, and then I will change the schedule to 2-1. And about 60% of the patients that change to the 2-1, they will be able to keep the 50 milligram dose with a reasonable toxicity and quality of life. So what retrospective data we have regarding this alternative schedule? Dr. Atkinson from the MD Anderson Cancer Center presented in last year ASCO GU an analysis. So they took almost 200 patients that had significant toxicity on the 4-2 schedule, and about half had a traditional dose reduction, like in the COMPARS, to 37.5, and another half switched to the alternative 2-1 schedule. And there was a significant difference in terms of a median on treatment time and overall survival. And in a multivariate analysis, the memorial risk, not surprising, and the alternative schedule were associated with overall survival. So this is the study design, the COMPARS trial. Patients that had a toxicity on the 50 milligram dose were dose reduced immediately to 37.5. And this may not reflect the common practice, what we do today after 6 years of experience with sunitinib, because what we do today is that for patients that have significant toxicity on the 4-2 schedule, we keep the dose and use an alternative schedule in order to keep sunitinib dose intensity. So an open question is whether an alternative schedule in the COMPARS trial would lead to a better response rate, PFS, and overall survival with sunitinib. I just want to show you that in the COMPARS trial, there was an unusual high rate of dose reduction and treatment discontinuation for sunitinib. more than half of the patients had dose reduction, and about 20% had treatment discontinuation. Now, these are very unusual rates. Look at the pivotal trial of sunitinib versus interferon, only about 30% dose reduction and less than 10% treatment discontinuation. And same figures for real-life data, our American-Israeli database, Dr. Schmidt again from Vienna, again, 30% dose reduction and about 10% treatment discontinuation. So, in my opinion, this data may be problematic and do not reflect the reality what we see in our daily practice. For example, in the COMPARS trial, most of the treatment discontinuation were due to cytopenia, which is a rare cause of treatment discontinuation in the reality. And of course, that extra and very high rate of dose reduction may influence sunitinib exposure and therefore the response rate, PFS, and overall survival. There is an open question, a second open question of the COMPARS trial regarding the timing of scans. So we know that in a patient treated on the 4-2 schedule, during the 2 weeks of therapy, there is a rebound of the VEGF system. And about 20% of the patient will show some clinical and scans progression during the 2 weeks of therapy. And this progression is probably RECIST relevant, but I'm not sure that it is clinical relevant because you have, again, a downstage of the disease with a reinitiation of therapy. So scans are always done on treatment. In a patient that is treated on the 4-2 schedule, you do scans on day 28, the last day of the on-treatment interval. This is the only type of patient that I specify the date of the scans. And this is supported also by different guidelines. Now, Dr. Motzer in the New England Journal of Medicine in 2007, in the pivotal trial of Sutent, performed tumor assessment, performed scans on day 28, the last day of the on-treatment interval. And suddenly, 6 years later, in a way that clearly unfavored sunitinib, disease assessment, the scans were done 2 weeks later, during the last day of the off-treatment interval. So again, this is a problematic study design that clearly unfavored sunitinib because they did scan during the last day of the off-treatment interval in contrast to what we do today. Because what we do today is to do scans during the last day of the on-treatment interval 2 weeks earlier to truly assess sunitinib efficacy. So again, this is an open question whether doing scans as we do in reality 2 weeks earlier might affect the response rate, the PFS, and the overall survival as reported in the COMPARS trial. The third open question regarding the COMPARS trial is the response rate for sunitinib that was much lower than was reported previously in clinical trials and in real-life data. So we have the pivotal trial of Dr. Motzer with a response rate of almost 50% versus interferon in his last update in the JCO 2009. Dr. Molina reported in the ASCO 2012 a response rate of almost 40% in more than 1,000 patients treated with sunitinib in 6 clinical trials. So why is the response important? Why you as a practitioner would like to choose the agent that is associated with the highest response? Because probably it is associated with the progression-free survival and the overall survival of the patient. This is the data from Dr. Molina's ASCO presentation, and you can see the significant difference between responders and non-responders in terms of progression-free survival and overall survival. We also have some real-life data. Our American-Israeli database, a response rate of about 44%. Professor Schmidinger from Vienna reports a response rate of about 50% on sunitinib. So again, some of us think that on-treatment scans and alternative schedule following toxicity might have resulted in a more realistic response rate of sunitinib rather than what was reported in the COMPARS trial. The fourth open question regarding the COMPARS is a subgroup analysis in this trial. So there are two main subgroups in a non-inferiority trial. We have the ITT population, the intent to treat, which comprises all randomized subjects that signed an informed consent. This is the most important population in a superiority trial. So we are, as oncologists, used to the ITT population. However, in a non-inferiority study, the per-protocol population is probably more important. So what's the per-protocol population? It's a subset of the ITT population that excludes subjects that didn't get active therapy, like for consent withdrawn, or those that had a major protocol violation or were lost for follow-up. So in the COMPASS trial, about 10%, more than 100 patients had major protocol violation or didn't get active treatment or were lost for follow-up. So the per-protocol population is less than 1,000, and the ITT population in COMPASS trial is more than 1,100. So this is a big difference between the two populations. Now, in contrast to superiority studies, regulatory agencies like the FDA or the European Agency have concerns in using the ITT population as the primary analysis for non-inferiority study. This is in contrast to superiority studies. So the per-protocol population is more appropriate for analysis of non-inferiority trial, and it is often required to demonstrate non-inferiority in both analyses. So you need to show non-inferiority in the ITT and the PP in order to declare that this is a true non-inferiority study. So this is what Dr. Motzer reported, a non-inferiority of pazopanib versus sunitinib, 1.1 months difference, but this is the ITT. This is the intent to treat population. But look at the PP population of the COMPASS trial. Now the difference is almost 2 months, 8.2 versus 8.4 for sunitinib. So the difference is higher, and the upper bound of the hazard ratio in the per-protocol population becomes more than 1.25, which was the predefined upper bound of the hazard ratio to declare non-inferiority. So the per-protocol analysis in the COMPASS trial didn't meet the non-inferiority criteria requested per protocol. By the way, the European agency requested an upper bound of less than 1.22. Now this raises a significant concern. Is pazopanib truly non-inferior to sunitinib? Because the PP analysis is not aligned with the ITT analysis as requested for non-inferiority studies. Now, again, in non-inferiority study, the most important point to look for is the upper bound of the hazard ratio. This point is the most important point in a non-inferiority study. You care less about the absolute value of the hazard ratio or the p-value, you care more, because what does this mean? It means what's the worst scenario that you are willing to accept as a worst outcome in the new drug versus the standard of care. So if you take a 1.25 upper bound of hazard ratio, you tell yourself that you are willing to accept a worse outcome of about 25% with pazopanib versus sunitinib. And finally, a fifth open question that I find in the COMPASS trial is the toxicity and quality of life as reported. So this is an open label study. So subjective assessment of adverse event when you know what therapy the patient got might of course influence the report of the toxicity. And second, the quality of life assessment regarding timing clearly unfavored sunitinib. It was performed on day 28 of each treatment cycle, with, as you know, it's the worst day of sunitinib. Now one may wonder why the quality of life performance assessment was done on day 28 and the scans were done 2 weeks later. Why weren't they done during the same day? Why is this discrepancy between the timing of scans and the quality of life? In last year, SNOMR, there was an interesting presentation of the quality of life of patients treated with sunitinib versus interferon in the pivotal trial. So they compared the pivotal trial of Dr. Motzer in 2007. So they compared the quality of life on day 28 versus 2 weeks later, the end of the off-treatment interval. And there was a significantly better quality of life if you assess it on day 42, the last day of the off-treatment interval. So like many things in life, the quality of life of sunitinib is really a matter of timing of assessment. And last but not least, we don't know how the common sunitinib 2:1 alternative schedule compared to pazopanib. We only know how the 42 compares to pazopanib. In my personal experience, again, pazopanib is probably easier than the 2:1, but the 2:1 is easier than the 42, and then it becomes less of an issue if you compare the 2:1 to pazopanib. So let's go back to our patient just to remind you, a 68-year-old man with a cytoreductive nephrectomy for metastatic clear cell RCC with multiple lung and bone metastases. Hang risk was intermediate, and the patient was started on sunitinib on the 50 milligram dose on the 4-2 schedule. He was also started on zoledronic acid because of his bone metastasis. After 6 months of sunitinib therapy, treatment schedule was changed to the 2-to-1. Again, it's not registered, it's not approved, but we do it in order for the patient to keep the 50 milligram dose, the dose intensity, while decreasing the adverse events. And the patient tolerated the 2-to-1 schedule pretty well with no significant toxicity. He had some fatigue, thrombocytopenia grade 1, he got ACE inhibitors and beta blocker for hypertension. Now, the patient response to therapy was stable disease at 3 and 6 months, and then later on, a partial response at 9 months, and a maximal response at 50 months. And this is a very important message. In patients treated with TKI, you need to be patient, because per our American-Israeli database, the initial response, the first scan at 3 months, you can see a partial response in about a third of the patient. But later on subsequent scans, the partial response is seen in about 44% of the patient. So you have a subgroup of patients which will respond later on, and you need to be patient. Now, when we did a multivariate analysis to see which patient with an initial stable disease will respond later on, then keeping the dose was a significant and independent factor. So an unnecessary early dose reduction may deprive the patient from a maximal benefit. Now, in our specific patient that I'm presenting, if due to adverse event at 6 months, when his disease was stable, we would reduce the dose to 37.5 like the COMPASS protocol, the patient might have not responded later on versus changing the schedule to 2-to-1 like was done in this specific case. So sunitinib was continued for